What causes inequity in liver cancer incidence and who might be disproportionately affected?
So disparities occur due to distinct distribution of risk factors among distinct populations. And as you know, the main etiologies are hepatitis B virus, C virus, alcohol intake, and metabolic associated steatohepatitis. There have been some studies, not so many, but some studies addressing the concept of disparities related to HCC. The main conclusions are that there are differences, particularly in the implementation of surveillance programs. As you know, in Europe, implementation of ultrasound and FP is around 70% of the target population, cirrhotic patients. In the US is around 30%, and most of the populations in which there is a significant decrease in the implementation of surveillance are African Americans and Hispanics. And as a result of that, there is a decrease in early detection and a delay in the implementation of treatments. This delay has not only been detected at early stages, but also at advanced stages, particularly associated with African Americans, but also associated with populations with high poverty. There is another area in which disparities has an implication is in the inclusion of patients in the setting of clinical trials that is significantly lower also for these populations of African American and Hispanics.
What impediments exist to preventing and treating liver cancer, and what could be done to address them?
Well, the first area in which we can have a huge impact is increase awareness and access to antiviral therapies for hepatitis C, vaccines for hepatitis B virus infection, and also public health policies related to decrease the alcohol intake and also some lifestyle measures related to metabolic syndrome. The second is to increase the awareness of patients, particularly those cirrhotic patients that are at risk of developing HCC, to include them in surveillance programs. And the third one is to implement equal policies of access to therapies, both at early detection and also at advanced stages of the disease. The distinct etiologies and distinct ethnicities and racials should have access to all the therapies available equally. So these are the actions that might be recommended to prevent the delay in the access to these therapies.
Cancer inequalities are a significant challenge in the cancer care space. Can you tell us about the EcoPulse initiative?
The existence of cancer inequalities we've known about for a long time, and many people have done fantastic work at trying to chart what those inequalities look like and bring forward the data. What we've maybe been missing is having that data in one place and being using all the sort of available tools we have now to make data comparable or to go and explore that data in a way that your neighbor could use, so that you don't necessarily need to be an academic expert to do that. So that's the idea with the Pulse, that we bring forward lots of fields of data in one place, make it as usable as possible, and with the purpose of driving better cancer policy as a result, that those insights can mean the investments into tackling inequalities are better made. And we can also chart where we see improvements and look into why that has been, what makes the difference. All of that is so important if we're going to have evidence-led high impact cancer policy in Europe.
What is the National and European Parliamentarians for Cancer Action Group, and how will it tackle inequalities in European cancer care?
The National and European Parliamentarians for Cancer Action is an initiative that's very allied to the European Cancer Pulse, because it's one thing to get hold of the data on inequalities, but things need to happen with that data as well. So the concept is, in every country in Europe, there are fantastic political champions for action on cancer. We want to bring them together and help them to learn from each other, help them be inspired from each other, but also give them that data, that evidence that is going to help them in making improvements in their own country. And what we also find is that one politician can inspire another politician in another country. I'll just give an example, which would be, for example, in Romania, where one senator has really driven the uptake of a new law to protect cancer survivors from discrimination by financial service providers. And that, we think, can be really inspiring to every country in that region, especially when a country looks a bit like your own. You know that what's been achieved is not the impossible, it's very doable. And that's what we want to see with the national and European parliamentarians for cancer action.
How does this tool complement the European Cancer Inequalities Registry and other initiatives of the Europe's Beating Cancer Plan?
Europe's Beating Cancer Plan is a record level of investment by the European Commission, the European Union, in helping countries work together to fight cancer. And in that are some significant goals, like creating a tobacco-free generation, eliminating HPV cancers, and creating new infrastructures like the EU network of comprehensive cancer centres. But we've always said, in embarking in such an ambitious plan, it's very important to measure and monitor the progress, so that if we see in one area things are slightly falling behind, that can be addressed and a refocusing of policy can take place as a result. So we hope that our Cancer Pulse provides a contribution to that measurement environment. And it goes slightly beyond aspects of the European Cancer Inequalities Registry, because it is spanning across the WHO European region, and it can hold or reflect data that may not be, for example, readily comparable in every single country, but still gives us insights. And take as an example, ethnicity and cancer. We know that the data field for that across Europe is extremely patchy, but where we do have data, we should try to capture that, because insights can still be given.